Hello, this is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, on behalf of the International Cardio-Oncology Society. Today we present highlights from a recent webinar discussing the therapies involved in chronic lymphocytic leukemia, with a particular focus on the cardiovascular complications. The early portion of the webinar highlighted the significant improvement in outcomes over the last few decades for patients with CLL, as well as the importance of comorbidities. Our presentation today is by Dr. Alessandra Ferrajoli, who is a hematologist-oncologist in the leukemia department at the MD Anderson in Houston, Texas. Dr. Ferrajoli is a graduate of the medical school at the University of Perugia and completed residency, fellowship, and advanced training in Houston at the University of Texas and MD Anderson. She has a particular focus on chronic lymphocytic leukemia. Our highlight today will focus on the cardiovascular comorbidities. While the association between atrial fibrillation and therapy for CLL is well known, today's highlight will focus more closely on the relationship between therapy and hypertension. As always, we highly recommend that you visit the ICOS website at ic-os.org, and there you can find an increasingly comprehensive source for education in all things cardio-oncology.
Those are the BTK that we will focus on today because this is what our data are about. Ibrutinib, Acalabrutinib, and Zanubrutinib. Ibrutinib is a first-generation BTK. Acalabrutinib and Zanubrutinib are a second-generation BTK. When we look at the NCCN guidelines, they are both considered first-line agent of choice for treatment of chronic lymphocytic leukemia, with Acalabrutinib and Zanubrutinib now preferred over Ibrutinib. And this has to do with their it's a reflection of their kinome profile. As we can see, Ibrutinib is the one that inhibits the largest number of kinase, as the kinome profile that is less selective. And we do feel that maybe some of the inhibition of other kinases, particularly TEC, can be affecting the cardiac arrhythmia that we see, and ITK may be affecting the bruising and activity of the platelet that we see. We really don't know exactly what is the kinase, possibly the off-target kinase, that may be responsible for hypertension. But moving to the second-generation BTK inhibitor, we see how the kinome profile of Acalabrutinib is the most selective, and Zanubrutinib is somewhere in between Ibrutinib and Acalabrutinib. However, interestingly, it is the one that is associated with the least number of atrial fibrillation events so far. So it is possible that the kinase that affect hypertension and the one that affect the risk for atrial fibrillation are probably different. So we and others have published extensively on the hypertension in patients treated with Ibrutinib. The mechanism is, again, unclear. We are not sure. It does not seem to be related to VEGF, that we know is a mechanism of hypertension for other drug use in the field of oncology. We see new hypertension or worsening hypertension in as many as 78% of our patients when we look at all lymphoid malignancy, and 71% when we focus on chronic lymphocytic leukemia. Many of my patients come to my office, and when I point to their suboptimal blood pressure level, they say that this is due to the Houston traffic and how much they struggle to get to MD Anderson and navigate through the medical center. But actually, this is not true. This is a real phenomena, and it can be of grade 3 or higher in up to 1/3 of those patients. What our study particularly focused, the study that was published by one of our fellow, Max Gordon, that now is is an attending at NIH, is that it really worsens over time, and we follow our patient for over 4 years. And unfortunately, we oncologists are not very good at managing hypertension, and there is often a lot of resistance of our patient to go back to their primary care physician or to the cardiologist when we point that they do need better management of their hypertension. I have to say that there is probably also a multifunctional component, because patients on BTK inhibitors, they tend to gain weight. They also tend to gain muscle. It's probably due to a direct effect of this drug, but also due to the fact that this patient feels so much better once their disease is under control. So many factors contribute to what we see during treatment with ibrutinib. This is the data from our study. We followed 300 patients for up to 5 years. All of them were followed for over 4 years. And we saw a new onset of hypertension in 69% of these patients, a worsening hypertension in 38%, and in 48%, their diastolic blood pressure increased by more than 10 millimeters of mercury. And we document severe hypertension in 62% of the patients and very severe in 19%. But what I wanted to point out is that a number of these patients discontinue treatment, either because they achieve a good enough response and we felt comfortable in discontinuing, or because the disease may have progressed. This was not only frontline patient, was patient with all line of therapy, or because the chronic toxicity were such that the patient requested change to a different drug, and over time our availability of the second generation increased. And what we notice is that once they change their treatment, only 11% of the 71 patients that discontinued treatment had persistent hypertension or recurrence of hypertension. This kind of was a proof of principle for us that there was really a responsibility or a cause effect related to their BTK inhibitor. I don't need to remind this audience that there are cardiovascular and renal complications of hypertension. We summarize this in this table, and we saw a small number, but of course relevant, of intracranial hemorrhage in this population, but we also saw borderline significance, a trend toward new or worsening renal function that we felt was very important to point out more to the oncologist than to the cardio-oncologist. We, as I said initially, the 3 BTK that we most common use have different incidence of cardiovascular toxicity. Atrial fibrillation on the top part of this table that was derived from the review of Dr. Christensen is 5 to 16% in patients treated with ibrutinib, 4 to 9% in patients treated with acalabrutinib, and 0 to 2% in the different reports in patients treated with zanubrutinib. Hypertension, interestingly, highest seen in patients treated with ibrutinib. This is all review of clinical trial. Lowest with acalabrutinib, 5 to 9%, and somehow in between in patients treated with zanubrutinib. Of course, I think we also need to point out that documentation of atrial fibrillation, I'm comfortable, is pretty good in patients treated in clinical trials, but documentation of hypertension, I'm not sure is very good in patients treated in clinical trials run by leukemia physician. Our group, our PharmD group, published a report that I was happy to mentor of what happens to those toxicity in our patient treated outside of clinical trial that we transition from ibrutinib to acalabrutinib, so a real-world experience in patients that we transition from ibrutinib to acalabrutinib. We noticed that The recurrence of atrial fibrillation occurred in 5 of 9 patients. The recurrence of hypertension only in 1 of 5 patients. And there was kind of a similar incidence in terms of major bleeding. But as far as hypertension, again, a small number, but only 1 of our patients that transitioned from ibrutinib to acalabrutinib had a recurrence of hypertension. This is the work that I want to highlight in this review. This is an abstract that was actually presented at the last year American Society of Hematology meeting. This was the 2023 American Society of Hematology, and we are about to start tomorrow our 2024 meeting. So I don't need to go in details of the introduction because it was really covered by my prior slides, but I want to focus on our work that was on performing a cumulative analysis of new or worsening hypertension using the Acalabrutinib Global Development Program and compare it with other real-world data on patients with and without CLL in terms of their hypertension. Those are the methods. We selected 11 clinical trials. Some of those clinical trials are acalabrutinib as monotherapy. Some are acalabrutinib in combination with obinutuzumab. Some of these clinical trials had a comparative arm that either was ibrutinib or what we call other comparators. Other comparators can be, again, either ibrutinib or more often is chemoimmunotherapy, mostly treatment with fludarabine, cyclophosphamide, and rituximab, or bendamustine and rituximab, that even if they're coming out of a preference, are still occasionally used in the community, and they represented up to now, in the past, what was the standard of care for these patients. And then they look at untreated patients with CLL in an early intervention trial that use ibrutinib as one of their arm in the early intervention, and also data from the population using several claim databases. Here we see the comparative prevalence of hypertension in patients with CLL. On the left is the claim database, and on the right is the clinical trial. And we can see that this is based on the claim database and based on clinical trial. There is really not a significant increase in the prevalence of hypertension in patients either treated with acalabrutinib as monotherapy or acalabrutinib plus obinutuzumab, that is a CD20 monoclonal antibody. We also look at the exposure-adjusted incidence rate of hypertension in patients with CLL. And again, we look at hypertension of any grade or hypertension of grade more than 3. And as we can see, really not a big difference compare in terms of incidence between acalabrutinib monotherapy, acalabrutinib plus obinutuzumab, and comparators. But we do see in the 264 patients treated with ibrutinib, as expected, a higher incidence rate. This is the exposure incidence rate in the same population, but focusing on new hypertension. And again, not much of a difference when we look at the 3 groups, acalabrutinib monotherapy, acalabrutinib plus obinutuzumab, and comparators. But yes, an increased incidence rate when we focus on the patient treated with ibrutinib. This is for worsening hypertension in patients with a CLL, same population, and kind of the same pattern where we see pretty consistent in exposure adjusted rates for acalabrutinib monotherapy, acalabrutinib and obinutuzumab. Comparators, again, a mix, mostly chemoimmunotherapy, but more frequent with the rate is higher with ibrutinib. So in our conclusion, we can say that hypertension was a common comorbidity in patients with CLL, and this was based both on claim database as well as clinical trial analysis. However, if we compare the different BTK, we do see that the impact of acalabrutinib on hypertension is really minimal, whereas the impact of first-generation BTK on hypertension is noticeable and should really be managed appropriately. And in patients where it can't be managed appropriately, then we should consider a transition to a different BTK now that we have more choices available.
I hope you enjoyed this excellent presentation, providing both a broad overview as well as specific new information regarding hypertension and the treatment of CLL. You may even want to visit the ICOS website and access the entire webinar, which contained additional excellent information. Please continue to look for additional educational content as well as further webinar highlights as we progress through 2025. In the meantime, we remind you to treat cancer, protect hearts.